KEYNOTE-048 was a three-arm study, and we randomized patients to pembrolizumab alone for up to 35 cycles, or to a novel regimen where they got the same platinum 5-FU backbone as the extreme regimen uses, but pembrolizumab was substituted for cetuximab, and they got that for 6 cycles, followed by maintenance pembrolizumab for up to 35 cycles total, or they got the extreme regimen, 6 cycles of chemotherapy and cetuximab, followed by cetuximab. And we did an overall survival analysis for patients who had biomarker-enriched PD-L1 expressing cancers and an overall population. And today I'm presenting the second interim analysis of the study. The final analysis will happen when the data are fully mature at a later time. So what we looked at first was the CPS 20 group. And so let me define CPS for you. Combined positive score is the ratio of PD-L1 positive tumor cells, lymphocytes, and macrophages to the overall number of cells counted times 100. So it's basically the percent of tumor and immune cells that are PD-L1 positive. And so for the CPS 20 population, if you looked at using pembrolizumab alone compared to the extreme regimen, it improved the median overall survival from 10.7 to 14.9 months. And the hazard ratio for that comparison was 0.61, and the p-value was 0.007. We also looked in the CPS 1 group, so at least 1% of tumoral or immune cells were PD-L1 positive. And the finding there was also that pembrolizumab was superior to the extreme regimen, extending median survival from 10.3 to 12.3 months, also statistically significantly positive. For neither group was progression-free survival quite as good as it was with the extreme regimen, and the response rates were slightly lower with pembrolizumab than they were with the extreme regimen. But for patients who had a response, responses were much more durable at over 20 months. The overall toxicity of pembrolizumab alone versus the extreme regimen was less, so fewer toxicities of all grade, fewer grade 3 to 5 toxicities. And we have quality of life data are not mature, not fully analyzed at this time. We then looked at pembrolizumab plus chemotherapy in the overall population, so without biomarker subsetting. And there we saw that the use of pembrolizumab plus chemotherapy was superior to the use of the extreme regimen at 13 months compared with 10.7 months. Here, response rates were comparable, progression-free survival was comparable. Again, responses were more durable. And so we feel as if pembrolizumab represents a new standard of care in first-line treatment, and for patients who are PD-L1 expressing, pembrolizumab alone is preferable to the extreme regimen.